Shall we start?
Yes, ma'am, we can start.
Good evening, everyone, and a very warm welcome to all of you. On behalf of the Tamil Nadu Ophthalmic Association, it gives me great pleasure to inaugurate today's webinar in collaboration with our young ophthalmologists, the future torchbearers of our specialty. This program reflects the strength of TNOA in nurturing academic excellence, leadership, and innovation among the next generation. I'm delighted to see such an enthusiastic participation and commitment towards learning, sharing, and growing together as a professional community. I extend my sincere thanks to the organizing team, particularly Prasanna, for taking so much of effort, the speakers and all the participants for being a part of this meaningful academic initiative. I'm confident this session will be informative, engaging, and inspiring for everyone. With that, I formally welcome you all and wish the webinar a great success. Thank you.
DC sir, a few words from you, sir.
Yes, Prasna. As usual, this young blood is really growing. It's nice to see you all grow and looking at focused topics. It is really good. If not now, I'm sure many will look at it in the YouTube. And nice to see the enthusiasm amongst all of you. So I'd like to give a session in the next coming TNOA. I was thinking of giving one session. I'll give 2 sessions for YOSI in TNOA at Coimbatore. And all the very best to you all.
Thank you, DC sir. Our president, Dr. Devakant sir, is also here. Sir, it's a great news, sir. Secretary, right from our secretary's announcement, and he's a scientific committee chairman as well for the next conference. Your words, Devakant.
Thank you so much, DC sir. And I'm sure by the next webinar, we'll have 3 sessions. And thank you so much, Sujata ma'am, for taking the exceptional leadership that you have in encouraging young ophthalmologists and giving us opportunity every time. It's a great honor for us. And as DC sir said, these focused webinars will usually help our audience a lot. And thank you again, TNOA, my second home, for giving YOSI this opportunity. So look forward to this amazing webinar. Thank you so much.
Thank you. Thank you, Devakant sir. So with that, we'll start this event. So under the leadership of Madam President Sujata ma'am, the TNOA Young Leaders Forum was one of the committees that Madam envisionized. And today we are in association with YOSI. And this committee has done programs like conferences, how to make it count, and this committee has done imaging webinar series of all the imaging modules we have done, and here we are with the orbit today. But apart from that, if you see the whole spectrum of this task force, in the last 3 years, we have done multiple events. Again, during the previous presidentships, we have had 10 capsules, and the views also speaks for itself. When the young ophthalmologists, we have left no stone unturned when it comes into FICO, social media, mentorship, travel grants, and we are finances. And this team is also taking part in all of digital task force initiatives. And it has given an AI webinar, which was well attended. Again, this was one of the previous capsules of this team. And today here we are for the Young Leaders Forum again. And I would like to acknowledge the whole team behind this. A special mention from Dr. Niranjan from TNOA side and Dr. Lipi Mittal from YOSI side. I think they both really gelled and got the whole program going. And I think among the 3, I was the least sorted person, and I would like to acknowledge both of them for being a pillar and skeleton for this whole event, along with the TNOA Young Leaders Forum, Aditya, Pranesh, Shruti ma'am, Vinod sir, who have always been a pillar of support. So with that, we have a very focused session of PTOSIS examination or a clinical structured overview by Dr. Olika. And again, welcome our President Sujata ma'am, Secretary DC sir, again our YOSI President Dr. Devakant sir. And I hand it over to Dr. Niranjan and Lipi, who are our moderators. Lipi is joining us from Center for Sight Palwal, cataract and refractive surgeon, and Dr. Niranjan Karthik, again a dynamic executive members, both of them of YOSI, and Niranjan is also the MC member of TNOA as well. Over to you guys both to start the proceedings of today. Yeah, Lipi and Niranjan?
Yes, sir.
Yeah.
So thank you, Prasanna sir, and it is a huge privilege to be associated with TNOA, and thank you, YOSI, for giving me this opportunity. So today's session is about masterclass on TOSIS, and we have a stellar panel for the session. We have Dr. Ankita Aishwarya. She's a consultant oculoplasty and ocular oncology at PGI CH Noida. Dr. Aparna KS, she's a consultant orbit and oculoplasty at Chaitanya Eye Hospital and Research Institute, Trivandrum, Kerala. Dr. Isha Agarwala is a consultant cataract and oculoplastics from Drishti Netralaya, Dibrugarh and Rahi Netradham, Dehradun. Dr. Nupur Goyal, she's a consultant anterior segment and oculoplasty at Eye Care Eye Hospital and PG Institute, Noida. And ma'am is also the team leader of socio-cultural group IROC and also the managing editor of YO Times, YOSI. Dr. Puneet Jain is a consultant in charge at Dr. Agarwal's Eye Hospitals, Delhi NCR region. He is also the executive member and the team leader of Oculoplasty Focus Group YOSI. Dr. Sindhuja Mergasan, she is an oculoplasty consultant at Trinity Eye Hospital, Coimbatore and Palakkad. Dr. Vatsalya Venkataraman, she is the consultant at ASD Eye Hospital, Jodhpur. We welcome all the panelists. So today we have the speaker for today's session is Dr. Rolika Bansal. She is a consultant at Mahatma Gandhi Medical College, Jaipur, a very dynamic executive member of YOSI and OPAI. And I think this 1 hour webinar is short to enumerate her awards. She has multiple awards. And I would like to invite Rolika ma'am for her masterclass on TOSIS. Over to you, ma'am.
Thank you so much. Thank you, Sujata ma'am, DC sir, for creating this entire panel. I think it's very kind of you all to encourage the young ophthalmologists. And of course, our yes man, Devakant sir, who's always saying yes to nearly everything that we ask for as a part of YOSI. And I'm glad that Prasanna asked me to come up with this talk. Of course, he knows how thin I'm spread right now, but I never say no to him. So thank you, Prasanna. And thank you, Lipi and Niranjan as well. Thank you so much, everyone. I hope my screen is visible.
Yes, ma'am.
Is my screen okay?
Yes, ma'am.
Okay.
Perfect.
All right. So I'll proceed with the class that we have today. Just a second. Yes. So when we talk about TOSIS as such, I know that we're talking about TOSIS to the postgraduates and the young ophthalmologists and the general ophthalmologists. So I've tried to keep it with the basics. When we talk about TOSIS, it's actually a Greek word and it actually means fall. And when we talk about ptosis, it could be fall of anything, but we talk about blepharoptosis specifically, it means upper eyelid drooping with the eyelids in the primary position of gaze. So very often the word is mistaken and we should be taking care of the word blepharoptosis being used. But of course, if you use ptosis, it's not really wrong. And the Greek origin is something we should keep in mind. So before we go further, we should talk a little bit about the muscles which are responsible for ptosis over here. So of course we have levator palpebrae superioris, which originates from the lower surface of lesser wing of sphenoid, and it traverses under the roof of the orbit, and it goes and attaches at the superior orbital rim. And as you can see over here, it forms the Wittnall's ligament. These are very important structures or important components which we are talking about over here. And this Wittnall's ligament is actually a very tendinous, strong structure. And then it goes, from here, it goes down vertically and attaches all the way to the tarsus. So this is what superior levator palpebrae superioris looks like. And this is the anatomical component. And then it goes further, and LPS actually divides into small anterior slips and attaches to the skin crease. And that's how it forms the skin crease. and a part of it attaches to the superior tarsus, mostly to the upper two-third of the superior tarsus anterior surfaces
Dr.
where it
Rolika, 1
attaches.
minute.
And
No, I
yeah,
think your network is little slow. If you put off your video and talk, it'll be better. Audio will be better.
sure, sir.
Yeah,
Is this
go ahead.
better now?
Much better.
Okay, perfect, sir. So a part of it also attaches to the superior fornix. And of course, we should know that the medial and the lateral components of LPS are also existent, and therefore that's the entire span of levator palpebris superioris. And we must not forget about our Muller's muscle, which originates from the undersurface of the LPS and attaches to the superior surface of the tarsus. Now, before we go further, we should always remember that etiology always plays an important role. Now, in etiology, we have the neurogenic component, the myogenic component of ptosis or aponeurotic type or mechanical type or traumatic type. Now, what are these types and why is it important? Before you ever diagnose a patient of ptosis and before you ever plan a patient for ptosis management, you should know where it exactly came from. You should rule out every single component. So, talking about neurogenic ptosis specifically, why does it occur? It occurs because there is a disrupted innervation of levator or the Muller's muscle. And we talk about the disruptive innervation, it could be due to cranial nerve third palsy or due to Horner syndrome. And when we're talking about these components, we must remember that there are multiple segments that we need to look into. When you're talking about Horner syndrome, we should look out for even heterochromia iridis. So yes, neurogenic ptosis is a very important part. And the next etiology that we have in mind is myogenic ptosis. And myogenic ptosis is abnormal levator action, restricted motility, and facial expressions are also abnormal. So this is when we are looking at myasthenia gravis or myotonic dystrophy. These are the differentials. Or even we have chronic progressive external ophthalmoplegia where there is motility restriction or oculopharyngeal muscular dystrophy. And must not forget that you're looking for deglutition in these cases. So history is important. Again, the third part is the aponeurotic ptosis. This is the most common type of ptosis where dehiscence or disinsertion of levator aponeurosis occurs. And this is also the involutional ptosis, OPDs or clinics. And also we need to realize that this ptosis actually increases with age. So it's more common towards the older age group. And the next component that we have is mechanical ptosis. This is due to the increased weight or swelling or a type of traction on the eyelids internally, maybe because of symblepharon. So this is called mechanical ptosis. As you can see over here, there is a lesion on the left upper eyelid, which is causing the ptosis. It could be due to tumors, cicatrization, or even blepharochalasis. The next component or the type of ptosis is traumatic ptosis. This is where there is a history of trauma to the levator muscle. In this patient, the patient had had blunt trauma with a wooden stick, and therefore there was ptosis component. So component could be either due to penetrating trauma or even blunt trauma. The one thing that we must keep in mind after these 5 types is also the possibility of pseudotosis. What pseudotosis is exactly? It could be because of dermatochalasis, browtosis, hypotropia, thysis bulbi, enophthalmos, microphthalmos, or even if there is a contralateral eyelid retraction. Now, in this patient, do you think that there is pseudotosis or ptosis? Well, actually, this is a patient of an ophthalmic socket, and this is an artificial eye. And this is not really ptosis, so it's because keep it in mind when you're examining these patients thoroughly. Again, this is a patient that I showed in aponeurotic ptosis. Now, do you think this is pseudotosis? Isn't there a component of eyelid retraction in the right eye? Yes, there is. But at the same time, there is a definite ptosis component in the left eye as well. So you have to keep that in mind. Now, when we talk about history, there are certain factors that come into play. What is the type of ptosis? Now, what does the history give us? The history gives us the exact etiology. If you take a good, careful, meticulous history, then you can actually get the entire etiology right in front of you. What else do you assess? You get the severity of ptosis by the history. You get the complicating factors. Like, for example, that there is ocular motility restriction, then you have a complicating factor right there. If you have a faceless or expressionless faces, then you have a complicating factor. Then you can also assess what type of surgery are you going to plan, and what is the amount or the entire correction that will be required in your patients, and what is the safety and expected outcome of surgery over here that you're looking at. Now, how do you figure all these things? Now, you can imagine that how important the history is and how much time you really should spend on history and examination. That's why I've tried to put the entire component of history and examination as the highlight of the presentation. Now, when we talk about history, we are trying to assess the duration. That is exactly how long the patient has had the duration or had the ptosis. And also, what's important is age at onset. When exactly did the ptosis begin? That's the very important part. Whether the patient had it since childhood or whether it was, elicited after trauma. So every single thing matters. But what was the exact age? Older age group have a different presentation. Younger age group has a different presentation. And what's important also is progression, whether it was acute or chronic, and how did it progress? A slow deterioration or a gradual improvement? These things are extremely important because they differentiate your underlying etiology. Now, as we showed earlier, this is the etiology picture. We have neurogenic, myogenic, aponeurotic, mechanical, traumatic, and we have to rule out all of this just by the history. So what do we go with next? We look out for the aggravating or the relieving factors that the patient has had with the ptosis. Now, any double vision that the patient has, because if you're looking at the neurogenic or myogenic components, that is 1 and 2, we might have double vision in this patient, or we might have restricted motility. We should also ask for jaw winking. Now, how do we ask for jaw winking? That while you're eating food, does anybody else tell you that one of the eyelids move up or down? And when you're talking, does anybody tell you that your one eyelid is moving up and down? That's an indication of jaw winking. And it's okay to ask that, even though you can see it, but you can actually ask it too. You can have diurnal variations as well in these patients. We're talking about myasthenia gravis over here. And of course, myotonic dystrophy should also be kept in mind. Pain is definite component which should be kept in mind and can be present in trauma and even mechanical components as well. Any eyelid swelling, or whether the eyelid swelling is recurrent or not. Now, any recurrent eyelid swelling will eventually cause aponeurotic ptosis in the patients. And is there any difficulty in swallowing? We did look at oculomuscular dystrophy, right? So that is when we are looking at when there is pharyngeal component involvement or not, and whether the patient explains to you about muscle weakness. Often the patients say, and I think we all have learned it in MBBS as well, that when I'm combing my hair, I find it difficult to comb my hair, and by the evening it's difficult to comb hair. So rubbing of eyelids or sleeping prone, this leads to floppy eyelid syndrome, and you must ask about that as well. Any lesion over the eyelid, even though it's evident, but you can ask for a history that did you have a lesion over the eyelid which was removed or not, and any component of allergic conjunctivitis or vernal keratoconjunctivitis in the past. That history matters as well. Now, further going to the trauma part, any mechanical, blunt, or chemical history. Chemical history is also important because there can be symblepharon formation. Again, forceps delivery. I get a lot of patients where forceps delivery has occurred in the past, way in the past. And it's okay, even if you have a patient presenting at the age of 35 years, it's okay to ask them that did you ever hear it from your mother that you had a forceps delivery or it was a prolonged or difficult labor? And eyelid or ocular surgeries, any patient who underwent any of the surgeries can have that component. Rigid contact lens use is also a factor which causes ptosis. Botulinum toxin injection history is a very important history these days, and it's okay to ask that as well because it causes a component of ptosis. However, it resolves on its own, but yes, you should keep it in mind. You should ask out for a family history as well, because in cases with CPO, etc., we are looking for a family history. any systemic illness that the patient has had. Medication history is very important. Now, drugs like morphine, oxycodone, heroin, hydrocodone, pregabalin as well, and even chronic use of topical steroids. It is very important to elicit this history. Any blood thinners, now that's important in any surgery, but yes, specifically in ptosis surgery, it is really, really important. Even though you're looking at very thin marginal arcade, if it bleeds during the ptosis surgery, it makes the entire surgery very difficult. Very important to ask for old photographs. I always ask for the patient's photographs right from the childhood because I can date back where the exact ptosis began. Patients often don't even realize that they've had the ptosis since a long time, but they say 2 years or 3 years. But like for example, in this patient, there is a component which just began in the left eye and eventually gradually it was progressive. So we can date it by the old photographs. Now, coming to examination, appropriate methods, because you will get patients of the younger age group as well, and you should make sure that it's an age appropriate method. Assess amblyopia, because yes, you have to treat a case with a complete ptosis, say for example, who has amblyopia. Correction should be done if it's a younger child. Temporary correction should be done by the age of till the age of 16 or so, and after that a permanent correction can be done because you don't want the child to be developing amblyopia. And laterality is extremely important, whether it is unilateral or bilateral case. And what's important is facial asymmetry, any abnormal head posture, and even, as I said, expressionless face is very important. And we should look out for visual fields because now here we're looking at the neurogenic components, but of course, even a ptotic eyelid, and it does cause visual field deficit. In fact, if you're planning a patient for blepharoplasty, and if you see a brow droop and an upper lid droop, please do the visual field assessment and you will be amazed as to the results that you get. And you should also do fundus examination because you do have a retinitis pigmentosa component in some of the cases with CPAO. Now, again, we have to look out for skin quality. It's, as you can see over here, the skin is slightly pigmented and wrinkled, and that is a component of, you're looking at a component of blepharochalesis and dermatochalesis. You also look out for prolapsed lacrimal gland, floppy eyelids, or any rounding of the lateral canthus. This is of floppy eyelid syndrome. And another component you should look out for is brow ptosis or any lash ptosis that the patient is having, or any lesions over the eyelid, as we have discussed. They should be examined and treated as well. And then you should look out for strabismus, ocular motility, corneal sensations, and even tear function tests. So an excellent examination or the history and examination component for ptosis is so important, and you must keep out all of these things in mind before you actually go to measurement. So this is the part where you do history, examination, basic, and now you go to the measurement part. Now you should use a transparent scale. I've tried to keep it like this so that we can I can emphasize on the part that transparent scale is so important, so that you can see the the part behind it. Otherwise, you can also use a clean scale with a white tape at the back, because that kind of highlights the marking, and that's okay. These days we get very good white scales which are slightly transparent, because that gives out an indication of the reflex as well. So as you can see over here, palpable fissure height, that is basically the distance between the upper lid margin and the lower lid margin, and that's exactly how you measure it. And you can see over here in the left eye there is a ptosis component. Now, what is marginal reflex distance 1? That is the distance where you need a light reflex. And when you have the reflex and the distance between the upper eyelid margin, the center of the upper eyelid margin, that's called the marginal reflex distance. Now, in this patient, you cannot see the reflex. So what will you do? You will try to elevate the eyelid gradually. And as you're elevating the eyelid, you will be able to see exactly the distance that it traverses and reaches the light reflex. That is the distance that you call marginal reflex distance 1, and it is given in minus. So if you are elevating it as 4 mm, it would be minus 4 mm. The next component over here is marginal reflex distance 2. That is the reflex the distance from the reflex to the lower lid margin. That is the distance as shown over here. And the third that everybody really asks for is the marginal reflex distance 3. This actually was defined by Putterman, and this is the distance that the light reflex has from the upper lid margin in up gaze. And that was assessed actually to assess how much of levator was to be excised. But again, this is not used anymore in the current scenario. Now, based on the MRD1, we do have a differentiation or a grading of the severity of ptosis, mild, moderate, or severe. Now, this is MRD1. What you do not need to get MRD1 severity. Now, when you have 2 to 3 mm of MRD1, that is mild ptosis. 1 to 2 is moderate ptosis, and +1 or more than 1 is severe, like less than 1 is severe ptosis. But the amount of ptosis, that is the difference between the two MRD1, that is mild, moderate, and severe. And that changes. You see the number change over here. 1 to 2 mm of difference between the two is mild ptosis. 2 to 3 mm of difference between the two is moderate ptosis. And more than 4 mm of difference between the two is severe ptosis. But what we prefer to assess is this severity based on MRD1. Now, what is exactly lid crease distance? Lid crease distance is the distance between the lid crease and the upper lid margin in the down gaze. In the aponeurotic ptosis type, the lid crease actually moves up because of the dehiscence. And in cases with congenital ptosis, lid crease is often absent. And how do you measure the marginal crease distance? You ask the patient to look down, and then you ask the patient to gradually look up where the crease just appears. As you can see over here, this patient, I asked him to look down and slightly go up, and that's where the crease just appeared, and that's where you take the marginal crease distance. The one over here is indicating only the left eye, and this is not applicable for the right eye in this picture. And how do you assess the levator palpebrae superioris action? You ask the patient to look down, you obliterate the frontalis and ask the patient to look up all the way, and you assess how much the upper lid traversed. That is the levator palpebrae superioris action. Now, what's important is the Beard's grading. And I know that very often this is not known, but this is how you actually grade ptosis. That is on the basis of poor, on actually 3 to 4 mm, that would be poor, fair, or good. This is actually Beard's grading. This is what you should keep in mind, that LPS action, if it is 3 to 4 mm, it is poor. If it is 5 to 7 mm, it is fair. And if it is more than 8 mm, it is good. And this leads to the next part, which is very emphasized on, at least in my fellowship days, is Burke's rule of congenital ptosis. When you are looking at congenital ptosis, you are looking at LPS excursion, and you're also looking at final upper eyelid position. What does this mean? That if at all the LPS excursion is 2 to 3 mm, you should leave the final upper lid at the superior limbus. If at all the LPS action is 10 to 11 mm, then you should leave the upper eyelid position at a 6 mm of overlap. This is the end point of your surgery for congenital ptosis. And therefore, we also have another part of it is how much of resection you have to do. Also, a combination of how much the patient LPS excursion, how much of LPS will you resect, and how much is the amount of resection. Now, this table is often not seen and not given any value, but yes, the older people have given this for a reason, and you should keep in mind. For example, if a patient has severe ptosis, like say 4 mm ptosis with a LPS excursion of only 4 mm. So what will you do? If you have to do an LPS resection, you will do a maximal resection. But ideally, in this case, what we can do is you can do a levator advancement, or you can do a tarsofrontalis skin along with skin excision or not. So this is how you decide what is the amount of resection, what is the method of resection that you will use. Going forward is marginal fold distance. Now, marginal fold distance means what? This is very much confused with tarsal platform show. And to clarify, the actual correct word to be used here is marginal fold distance. That means that if the patient is looking straight, then the distance between the upper lid margin to the crease or to the fold, this is the distance called marginal fold distance, currently called tarsal platform show, but the older term is to be followed. The next one is brow fat span. That is the distance between the upper lid margin and the brow all the way. And the other one is vertical lid height. And this is assessed when the patient is looking in down gaze. So this is basically the distance from the brow till the eyelid margin in down gaze. And this is called the vertical lid height. The next component that you must assess is Bell's phenomena. Because if you are planning a tarsofrontalis sling, and if you have a poor Bell's phenomena, then you know that if the patient is trying to even close the eye, the cornea is always going to be exposed. So you must not correct the ptosis completely in these patients. Otherwise, you will have exposure keratopathy leading to poor visual prognosis. So over here, you're looking at Bell's phenomena is graded as good. That is more than two-thirds of cornea is covered as seen in this patient. Fair, when it is one-third to two-thirds of cornea is covered. You should also assess on a similar ground lag of thalamus, and that is where you have a component of eye opening on the when the eyes are actually closed, and you should assess that because post-operatively you have to counsel the patient regarding the possibility of corneal exposure. So a combination of Bell's and Lagoff should be kept in mind. Next is Herring's phenomena. That is when you elevate the ptotic eye, the good eye actually starts drooping down. And this is Herring's phenomena. Now, why do we keep that in mind? Imagine if you do complete correction intraoperatively of the ptotic eye. Now, if you are correcting the ptotic eye and to a level that is exactly at the level of the normal eye, and then post-operatively you will find that the normal eye droops down. This is because of the muscle innervation, or that is the contralateral innervation. The next is frontalis action. You ask the patient to use the frontalis completely, and then you assess the upper eyelid margin movement. That is the frontalis action. Next is the fatigue test. You ask the patient to look at your finger. We do it 20 times up and down, and that's how you get the fatigability test. Again, it's important more in the myogenic and the neurogenic component of ptosis, and so is the ice test. Ice pack test. You put it on the upper eyelid for 2 to 3 minutes and you will see an improvement or not. You have to assess that as well. Another component is synkinesis. As you can see over here, mouth opening or mouth movement on this side is leading to the movement of the upper eyelid. This is called synkinesis. And you should keep it in mind because there is a synkinetic innervation to the lateral pterygoid. And how do you grade it? It's mild, moderate, or severe, where there is an upper eyelid elevation of less than 2 mm in mild and more than 5 mm in severe. Now, what does this refer to? If it is mild, that means that the eyelid actually becomes symmetrical with the opposite eye. That is clinical improvement of ptosis. And if it is moderate, that is eyelid elevates till the superior limbus. And severe, if the eyelid goes way beyond the superior limbus and causes a superior scleral show. All these components should be kept in mind, and to actually in a way summarize it, or rather put it in a shorter way. If you have a good LPS function of more than 10 mm, then you can think about conjunctival Muller's resection because you're aiming at only 2 to 3 mm of correction. And if you have fair to good LPS function, you can think of levator advancement. That is, you're looking at residual levator function of 5 mm. This can be done in nearly all types of ptosis. But if you have poor LPS function less than 4 mm, then you need a brow suspension, either in the form of tarsofrontalis sling, or even frontalis clamp advancement can be performed. And this is where you're looking at residual of levator function of 5 mm. This can be done in severe ptosis. So to conclude, you have to have a clear understanding of ptosis. It is extremely mandatory, and you have to have you have to keep in mind the etiology because it must be ruled out for the treatment planning. If you have the history well thought of, an efficient, good treatment plan, examination is crucial for surgical accuracy. It's extremely important to have a good examination at your end. So be very meticulous, give it time. Aesthetic appearance has a psychological impact. Just yesterday, I had a patient who had probably 1.5 mm of ptosis and not much, and that to just the medial component. But the patient was extremely insecure about the fact, and it's okay to address their psychological impact because it makes a lot of difference in their lives. So you must hear the patient, but you have to still give a good counseling to the patient because they don't really need a surgical intervention if it's a very mild ptosis. It is important to know when to exactly operate, and what's more important is not to operate. So thank you very much, and this is all that I had to mention about ptosis aspect.
Thank you so much, Rolika ma'am. That was probably the most comprehensive coverage of ptosis evaluation. I'm sure all the PGs who have attended this are going to really benefit out of this for both their practical knowledge and as well as exam purposes. Because nowadays, asking those eponymous gradings and things, students usually know that, but they just don't know that it is that. So you've covered it very well for us. Thank you so much. We have a stellar panelist team on board. So I would like to take your 2 cents on ptosis evaluation. So we would like to start off with Dr. Nupur ma'am. Your inputs on ptosis evaluation, please.
Yeah, so first of all, I think Rolika, that was extremely well covered, right from the types of ptosis to the history and the examination. Extremely well covered. I really don't have much to add on to. Just a few more pointers. So when a child comes to you, uh, with ptosis, so a few pointers there that for asking for Marcus gun, in an adult you can take a direct history, but in a child, how you can ask for Marcus gun, you can ask the parent that during feeding, if they see the movement of the eyelid. So that is one pointer that can go across. Also, just little about the management of the congenital ptosis, especially in a child. When a child comes, what we do is gently, we assess. In a small child, it's very difficult to do the complete assessment of the levator action. Suppose a 1-year-old child or a 6-month-old child is coming to your OPD. So what we basically look at is whether the visual axis is clear or not. How much is the drooping of the lid? If the visual axis is clear, then we explain to the parents that in such a small child, probably directly going for a surgery is not very advisable because obviously a child would have to be operated under general anesthesia, and the only kind of surgery that you can do for the child at that time is a tablet.
Nupur ma'am, I think the audio is a little quivering. Is it just me or?
Is it fine?
Yes, ma'am. Yes.
Yeah.
Yes.
So where could you hear me? Yeah. So I said when a child, suppose a 6-month-old child or a 3-month-old child comes to your OPD with, ptosis. So how do you assess that child? So it's not possible to do all the evaluations like the levator actions in such a child. So what we basically try to look out for is the whether the visual axis is clear or not, whether you can see the pupil or not. And then you take a decision based on that. So if the visual axis is not clear, it's completely covering the pupil, then yes, you would want to do an early intervention in the child because you want to prevent amblyopia. So in that case, you tell the parents that we would be, going ahead with a temporary surgery, which is a tarsofrontal sling. This is just to elevate the eyelid in just enough so that the child does not go into a lazy eye or an amblyopia. If the visual axis is clear, then you explain to the parents that we'll keep monitoring the child every 3 months or every 6 monthly and keep checking on the visual acuity, making sure that there is no development of amblyopia. And probably once a child turns 5 or 6 years and he is able to cooperate with all the, the assessment of the levator function, and that is a time when the child starts going to the school and, starts facing the peer pressure of, getting teased in the school. That is a time when we can probably opt for a more permanent surgery if the levator action is fair. So that is my thing, which I wanted to. So every congenital ptosis surgery does not need a surgical correction. So you need to have a good evaluation, and it has to be customized for every child. So also you have to, weigh the risk of taking the child under general anesthesia for the surgery, and the main thing is you have to prevent amblyopia. So your management will depend on that. So that is my take on this.
Thank you, ma'am. Thank you, Nupur ma'am, for highlighting on the pearls for managing congenital ptosis. We have a few questions that we have collected from few residents and participants. I would like to ask the house on this. I just wanted the opinion of the panelists on experience with crutch glasses and how much, in your experience, do patients find it comfortable? I would like to take the opinion of Dr. Isha.
Hi, good evening. Thank you for the question, Niranjan. For the question you asked, crutch glasses are, very good options, especially for patients with very severe ptosis and a very, very poor Bell's phenomena. So, when we are examining the patient and say we really cannot go for a surgical intervention, as in the surgery is not safe for the patient. So those are the times, we can opt in for crutch glasses. So one is very, very severe ptosis with very poor Bell's phenomena. Also, there are multiple times, when you want to buy time for before going in for a surgery. Say sometimes we would have extremely old patients, they come in with aponeurotic ptosis bilateral, and the ideal surgical management would be an LPS reattachment, as most of the times the LPS activity would be good. But considering their age, they don't really want to go in for a surgery. At that time, those glasses can come in, handy. And yeah, these are the several options where we can go in for crutch glasses.
Thank you. Thank you, Dr. Isha.
Yeah.
Next question that we have for the panelists. This is in fact related to a practical examination. So, how to say in exams a complete diagnosis of ptosis? So this is something that's expected by examiners in one straight line, right? So I would like to ask maybe Dr. Aparna, if you can share your perspective on how would you recommend a complete diagnosis?
I think we can start with the anatomical thing, whether it is mild, moderate, or severe, along with the LPS function, just like a severe ptosis with poor LPS function, like that. And then what is our clinical diagnosis, whether it is congenital or acquired, and if acquired, what is the probable cause? That is what I feel. I think DC sir will be a better person to explain that for examination purpose.
Thank you, Dr. Aparna. Any other panelists who would like to add on to this? Most welcome to do so.
Yeah.
Yes, Dr. Ankita.
Yeah, so when we were doing fellowship, so Dr. Honavar had a very clear-cut thing that we have to write it in the below. So first thing, whether it's whenever we like in terms of congenital ptosis, whether it's, it's a simple or a complicated one. So I'll just give one example. Suppose we are writing simple congenital partial ptosis. So first thing, if it is associated with Marcus gun or any other complicating factors, then we call it a complex or a simple one. Second, definitely what Rolika also emphasized, that what was the mechanism? Is it a congenital or it's an acquired one? So simple congenital, where it's a partial ptosis or it's a complete ptosis, the third part. And then definitely you can have an association whether it's a whatever is the LPS action. So at least a student during the residency should be able to make it out whether it's a simple, whether it's a congenital or an acquired, whether it's a partial or a complete ptosis. So at least this much diagnosis should always be there with them. Secondly, you can add any on that to it, whether how is the LPS action or any other associations to it.
Thank you, Dr. Ankita.
So I also, just to add on to Ankita, I also prefer to mention the LPS action and the bells also, just for the completion, because that would also help us make the choice of treatment that would go forward. So this, I mean, that's what I tell my PGs to write. Mention the LPS action and the bells also, and the Marcus gun also. These three components I expect them to mention in the diagnosis.
Thank you, ma'am. So, most of the time, these patients are young and they come to clinics with wanting to get refractive correction also done. So, what is your take? Maybe Dr. Vatsalya can answer this. Should we go for ptosis correction first, or should we correct the refractive error first?
So that's a very interesting question. These days, when the refractive procedure started to begin with, right? So there are two basic categories we're looking at refractive correction based on what age bracket we're looking at, right? So if you're talking about something like a patient, and for example, a patient who's aspiring to, we're looking at LASIK, right? So I would suggest that we address the intraocular first before we address the extraocular. But at the same time, if you're looking at a patient who's 45, who's say looking for a refractive lens exchange, then we need to find out exactly what is the reason for the ptosis. Because if there are any senile changes which are also affecting, then we can maybe consider going ahead for a ptosis correction before the refractive correction. So that would be my take, but definitely I would like the senior panelists also to weigh in on this.
Thank you, Dr. Vatsalya, for your inputs. Any other panelists who would like to add anything regarding this? Okay. We have with us Dr. Shruti ma'am. So I have a question for ma'am also. This is something that I encountered in my practice. She's a dynamic part of our Young Leaders Forum and a very fantastic squint and pediatric ophthalmology specialist. Ma'am, again comes the confusion of when there is a coexisting squint and ptosis. So in that confusion, how do we get out of the confusion?
Yeah, I think it's been, thank you, Niranjan, to rope in PDOF also into this whole thing and giving me a chance. So, yeah, so I feel whenever there is a squint with the ptosis, I mean, it's established that we always do the squint part first.
Yeah.
Just makes more sense because if there is a hypotropia, again, you have a pseudotosis, you really can't assess well. And of course, if you're going to touch the SR, then there's again slips that are there that you would kind of alter the squint post-op, I mean, the post-operative outcome of the ptosis correction itself. So ideally, if it is a significant squint, especially in MEDs, then I would go in for a squint correction first and then followed up maybe a month or a couple of months until we see the stable response to the squint and then go in for the second procedure of ptosis. If it's a small squint though, then I do tend to collaborate with oculoplastic surgeons to do it together sometimes. And that also happens because sometimes you have to be practical. And if it's a horizontal squint and it's not really going to affect the ptosis much, then I do tend to, for smaller angles, I tend to collaborate with, do it together in one go. So I hope that answers. I have a couple of questions, if I may ask to the panel. The
Yes,
first
ma'am,
is,
please.
yeah, regarding the Herring's phenomenon. So you did mention that, you'll have to kind of lift up the other lid to see how the droop is. So now, how is that clinically significant? Do you operate for the total droop that is measured? Or that was my first question. The second question is in pediatric like in pediatric ptosis, I mean, what we do follow is that whatever the ptosis is, even if it is Marcus gun, if the visual axis is paired, and if the child does not have significant astigmatism, we tend to hold on. So is that still good, or do you have an alternate thing to it?
So I'll go for the first question, and I think I'll leave the second question for somebody else to answer. So as you asked, ma'am, that for Herring's phenomena, like why is it so important? If we have complete correction, so if you're elevating the eyelid and say the other eyelid, that is a normal eyelid, which was at perfect level, is actually drooping down by 2 or 3 mm. So we have to intraoperatively assess it. So as I said, say example, it is 2 mm droop. So what we try to do is we do a lesser correction so that anyways the other eyelid is going to droop down. So if we do a slightly lesser correction, then we will have the two eyelids meeting midway. Otherwise, what will happen is you will correct one eyelid completely and there's going to be a droop on the other eyelid. So if you're expecting a droop of 1 mm, then slightly do an undercorrection on this eye so that you actually land up having a midway or equal alignment post-operatively. So I hope that answers the question.
Yeah, thank you.
We have to counsel it to the patient parents preoperatively also. That
Okay.
other eye drooping is also expected after surgery.
Agreed.
Got it.
And what I believe is in ptosis correction, rather than just, lifting the eyelid completely, we should always and always try to match it with the other eyelid. As in giving a very good aesthetic outcome and a functional outcome is matching it with the other eyelid. It may not always be a complete correction, but yes, obviously always matching it with the other eyelid, because I think that will make the patients cosmetically and functionally also very, very happy patient.
Right, I agree. In fact, I would just add one more point over here, as Dr. Isha said, you should not do complete correction. Like, for example, I had a patient, we're not talking about Herring's phenomena here, but in one eye, I showed her pictures as well. She had complete ptosis, she had -3 mm of ptosis of MRD1 in the in the left eye. And the right eye was perfectly fine, but her motility was restricted. But at the same time, her vision was 6/6. Now she does want a slight elevation. She's not comfortable with crutch glasses. What do? So I corrected her eye just to clear the visual axis. So when I did it that way, so she's able to see clearly. We're not looking at an aesthetic equality here, but at the same time, she's able to close the eye as well. If I would have gone above that, she would have had a lag of thalamus as well and exposure keratopathy. So you don't have to really fulfill your ego by getting I hope that the alignment is perfect at the end. I mean, it's a beautiful feeling, but sometimes you have to think about the patient being like, okay, am I going to do justice to the patient's cornea going forward or not? So that's a part to highlight. An excellent point, Isha. Thank you.
Thank you.
And so I have a question. If when we are speaking about pediatric ptosis, since most of these patients are operated under general anesthesia, so do you readjust the sling or do you go with the preoperative planning, the amount of ptosis which needs to be corrected? Dr.
Yeah, we
Smith,
actually keep it adjustable. It's very often that we counsel the patient that we might need to go back in, and it's okay to do so. So in fact, it's better to tell the patient that your ptosis surgery is going to be in 2 stages. One is when we're going to correct it. Second, we will go back again after 7 days, because more often when you are giving, say, in local anesthesia as well, if you're giving a local anesthesia, there's going to be swelling post-operatively, and even the manipulation might lead to post-operative edema on day 1. You're not going to be able to assess how much it corrected. So by day 7 is when you're able to get the edema out, you're able to see the actual correction, and then you can decide whether you want a little bit of further correction or leave it be, or loosening or anything. So you should always keep your sutures flexible. So yes, that is something adjustable. I prefer doing that. Even if it's a TFS, I mean, of course, even a tarsophront sling, we're able to achieve it easily, but you can keep that in mind. It's not a bad idea.
Yeah.
Thank you, ma'am.
I think Lippy, Dr. Shruti asked some question about the ptosis in a child.
Markers.
So can I just take that up?
Yes, ma'am. Yes, ma'am.
Yes, ma'am.
So yeah, Dr. Shruti, so that's still the norm. If the visual axis is clear, at least I would want to hold on to the surgery. Because see, general anesthesia is general anesthesia at the end of the day. So any child that you're operating has to go under general anesthesia. So I would counsel the parents, even if the child has reached 5 to 6 years of age, and there is not much, social issue of being teased. Sometimes the parents are more apprehensive. I tell the parents that let the child grow up, let the child decide for himself, when he is of that age to take a decision about his body. Okay, and obviously, then I tell them that you get the surgery done now or probably at a later date, the results are going to be nearly the same. So, if there are no major issues, then just let the child be if it's okay. Obviously, we keep monitoring the vision, making sure that there's no amblyopia development. So, that is what I generally counsel the parents.
Great, thank you.
So that is my
Can I have one more question, please? Yeah. So there's a lot of talk about frontalis transfer also as a correction for ptosis. So can the panel take up like how it's popular, but how is it and what is your opinion on that?
I think I really appreciate the frontalis flap advancement as a replacement of tarsofrontalis sling. I've seen excellent outcomes with it. So when you are able to, in fact, it lands up giving a more aesthetic appeal, because with a tarsofrontalis sling, I mean, I'm not against tarsofrontalis sling at all. We just operated one in the morning today, but tarsofrontalis sling does give a slight like a slight bulky appearance. But frontalis flap is when, if you have a poor levator function, you know that you might not even be able to correct this at the age of 18, because you wait for the levator to develop completely for 18, and then you try to do a levator levator recession over there. But if you have a good frontalis and you bring it down to the tarsus and attach it, you're going to get a very good elevation, and you don't have to do a resurgery as well. So it's not a temporary procedure. It's like a temporary procedure becoming permanent. So it's a very good option, and I'm very comfortable with the frontalis flap advancement as well.
So do you think it's like going to be the first line in management, or when would you recommend this versus a tarsofrontalis sling?
We can never choose between one procedure and the other. It is very patient dependent. I do agree with your thought about the question, but the choice of the surgery depends a lot on multiple factors, whether the frontalis action is there or not, whether the patient is going to be able to sustain it or not. And there are patients who want a correction later because they've heard of things. You'll be amazed as to how much patients read on internet and come to you. They've not heard of frontalis flap advancement. They've heard of tarsofrontalis sling, and they would like that as only. So these are the things that you should keep in mind, and it's okay to be flexible between the two. And of course, if you are new to frontalis flap advancement, it's okay to do it conservatively initially and then get onto it. But you should try it for sure. It's very comforting after you see the post-op results.
Thank
And
you.
I feel it gives a very beautiful contour as well, the
Contour.
frontalis flap, yeah. Of course, the lift also and a contour also. So it
Yeah.
is definitely a very good procedure. Yeah.
Because it's a diffuse
Yeah.
elevation, not just at one point.
Yeah.
There's
And
no
we are
peaking.
kind of attaching the LPS also, like, there is a bridge flap that we create. So it gives really very good outcomes. But of course, our frontalis activity has to be there along with a poor LPS action. So I think it works on those kind of patients.
Yeah. And another thing that I would like to add, Nupur ma'am did mention, and I think you all were discussing about the GA part. Please remember that in general anesthesia, eye moves up. It does not stay in primary gaze. So don't try to correct the eye as it is, as per what you see. The eye has probably rolled up. Because so always bank on your pre-operative assessment than your intraoperative assessment. A lot changes there. So keep it in mind. The general anesthesia, you will have the eye moving up. In local anesthesia, you will have eyelid edema when you're injecting. So pre-op measurements always in sitting position.
Thank you, ma'am. So I would like to ask Dr. Sindhuja. This is a question from residents actually. How to counsel the patients who have got persistent ptosis post block, peripulvar block?
Hi. So first of all, I want to say, Rolika, that was a very nice, presentation. You covered everything very well. So this one thing that, we have seen so many patients after the peribulbar block where they have ptosis, even after a month of cataract surgery as well. But the only thing which you can tell the patient is reassurance, saying that it will go away on its own. Other than that, it doesn't need any other specific treatment or anything for that. And maybe while giving the peribulbar block, you can be a little bit more careful when you give it superiorly, maybe give the volume a little bit lesser. So other than that, I don't think anything else can be done for this. But yeah, I have seen many patients who come even after a month of cataract surgery with the effect of ptosis, but it does eventually improve and they do recover. But certain patients, especially after the superior rectus bridle suture, after the superior rectus bridle suture, if they have ptosis even after 2-3 months of cataract surgery, then it has to be evaluated properly, and maybe they will require ptosis correction for that. So you have to examine the patient after a month and 3 months after cataract surgery to decide accordingly what you can do about it.
Thank you.
Thank you, Dr. Sindhuja. I think we've had a very fruitful discussion with a very active and a dynamic panel. So, is there anything else anybody wants to add before we go ahead with the normal distribution of certificates?
I would like to add one thing.
Yes, Dr. Please.
I would like to emphasize that ptosis is not always a cosmetic, not merely a cosmetic concern or just defective vision, but it can be a part of some systemic diseases like myasthenia, Horner syndrome, or CPO with Carnster syndrome, like that. So always, I advise my PGs that we should make a habit of considering pupillary reaction, extraocular movement, and ptosis as a triad. If one of them is affected, always look for the other two, so we won't miss the life-threatening or red flag signs in ptosis. We should make a habit of considering these three together.
Thank you, Dr. Aparna. I think that's coming from rocking in many quizzes across the country, I guess, of the syndromic approach. Wonderful inputs. Thank you so much. Do we have anyone else?
I just have one question to the panelists. For neurogenic ptosis, right? Especially myasthenia or any myogenic, the dystrophy or anything like that. And suppose for myasthenia gravis, for example, the patient is started on medical management, but the patient has moderate to severe ptosis. So it is not only for cosmetic purpose, for the functional part as well. How quick do you usually operate after the patient is started on Gravitor?
Would anybody like to answer that, Dr. Isha?
Yeah, so for things like myasthenia, we usually wait at least minimum would be 3 to 6 months before we, want to kind of intervene for a surgery, because myasthenia somehow, even if not the complete ptosis, it resolves with medications and also a trial of steroid, like low dose, long course of steroid. But even if there is some amount of residual ptosis remaining, maybe we can go in for a surgery, but later on, at least we would wait 6 months, not before that, for sure.
So, just adding on to Dr. Isha's point, many
Yeah.
times myasthenia can, coexist with an aponeurotic ptosis as well. So,
Yeah.
after starting the medications that Dr. Isha mentioned, after 3 to 6 months, probably it has a component of the aponeurotic ptosis as well.
Yes.
So, yeah.
Yeah, totally agree with both of them, Dr. Isha and Dr. Nupur. Actually, we have also seen many cases of myasthenia. Among 80% of them resolves completely with the medication. The 20% whom we have to operate, we generally have operated after 9 months, and those actually had those aponeurotic component. So in medical, if it is mostly due to myasthenia, it will resolve max by 9 months. What we have seen.
Yeah. And I would just like to add, it's okay to do MRI if you are suspecting a neurogenic component. A lot of people have this conservative thought process. I think we have gone from a timeline of very expensive MRIs to a more reasonable zone of MRIs. And if you are looking at something like a third nerve palsy, and if you're looking at a neurogenic myogenic component mixture, it's okay to get one MRI to be clear if there is any lesion in the brain or not. So just to keep that in mind. I mean, I am pretty flexible with, I don't know if others disagree. If the patient is affording and if you can, you have things around you, please do one MRI with orbit with brain with contrast. Yes.
Thank you, dear panelists, for your valuable inputs. So, if there are no more comments or questions, it is my privilege to be presenting the certificates to the wonderful people on board, starting off with none other than Dr. Rolika Bansal, ma'am. So, thank you so much for giving us a totally comprehensive package of doses. I think this is a module that I think PGs will definitely would want to refer before their exams as well. Right. Then my co-moderator, Dr. Lippy, for me being such a pivotal person in making this happen, bringing together such a wonderful panel on board. And starting off with the panelists, Dr. Ankita, Dr. Aparna, Dr. Isha, Dr. Nupur Goel, Dr. Puneet, and Dr. Sindhuja. So thank you so much, and Dr. Vatsalya, of course. Thank you so much, each and every one of you, for joining us on this weekday evening and giving such real pearls from your practical experience. I think it makes so much difference to all the people who have joined us on both Zoom and YouTube. And personally, we all learned a lot about TOSIS, much more than what we knew before. So, any concluding remarks, Prasanna sir?
Yeah, and before
Anything?
we close, so I'd like to thank our president, madam, a few words from ma'am, where I would like to acknowledge again on behalf of TNOA side, Dr. Niranjan, and on YOSI side, Dr. Lippy. Again, they both, ma'am just told that you guys got it ready in 24 hours. It would have not been possible without Lippy Mittal and Niranjan Karthik, who worked along with me to get this collab going. So thank you, ma'am. I think we had a very different one compared to what we were having, a single talk followed by a succinct discussion. Again, one of the ideas which we conceptualized when discussing with our president. So over to ma'am for the final closing remarks, if any.
As usual, it was an amazing webinar. I think this focus on one single topic, I think it's really going to be very useful for the postgraduates, and they can always go back to it whenever they want because it's available on YouTube. And the talks were amazing, the discussions were fantastic. And I really learned a lot because I'm not an oculoplastic surgeon. So, I mean, I went back to my PG days. Really very excellent talks and wonderful discussions. Hats off to all of you and keep it going. That's what I would say. Thank you.
Thank you, ma'am. Ma'am, a few words from our task force, or rather the Young Leaders Forum, which you innovated in your presidentship.
Yeah,
and,
sure.
Shruti ma'am is here, Vinod sir and Pranesh. A few words from you guys. Aditya, if you are also there around. Yeah, Shruti ma'am.
Yeah. So once again, I have to thank Dr. Sujata ma'am for taking up this initiative of the Young Leaders Forum. It was something completely out of the blue, and it was something novel. And we were wondering how are we going to contribute to this. But then again, she picked like the right set of people with very different set of strengths. So I think that's something only a leader can do, because she picked one person who was good at one thing and then just put this team together, and she had this fabulous thing going immediately. And we've had really good meetings and under the leadership of madam, and there are a lot of great ideas we discussed, and we are executing them one by one, and that's something truly amazing. And we're trying our best because she keeps motivating us to keep doing more and more, and she's like, this is not done, that not done, do it. So I think that's great. And I think Prasanna and Niranjan have really taken it to the next level. Sometimes it just happens that you have a great team, and then it just comes together. So thank you so much, madam, for this opportunity for us, yours, and it's a great thing to collaborate with TNOA on this. And again, Rolika, what a fabulous presentation. I mean, what I really picked out was these amazing photographs. The archiving and the kind of imaging and the quality of the images were fantastic. Congrats again on this talk.
Thank you, ma'am.
Vinod sir.
Rolika, it was a super presentation. I have been heard about your presentation. First time I'm listening to your presentation. It was excellent talk. And thank you, Sujata madam, for this Young Leaders Forum. I think no president would give such a free hands to the young minds. Whenever we contact her at any time, madam will immediately respond, and a word from madam will say, go ahead. That's I don't think any president would do that. Thank you, madam. Thanks for the opportunity. with the wonderful leadership. 6 months we just it passed just like that. And thank you, ma'am. Thank you for the opportunity.
Ganesh?
It was really great. I think it's a TOSIS masterclass, and I really thoroughly enjoyed it. Every moment of it, it was exceptional, and a nice presentation, Rolika. And big thank you to Sujata ma'am and DC sir for this initiative. Actually, it was very enjoyable. Actually, I learned a lot. I was really earning that the discussion will still go on. We can understand more of the nuances of TOSIS. So it was a pleasure listening to people speak.
Thank you. Thank you. Adit, if you are around, Dr. Aditya. Yeah. So I think that brings us to the end of this TNOA Young Leaders Forum in collaboration with YOSI. So in the last 6 months, this has been the 6th or 7th capsule that we are collaborating. And on that note, DC sir was kind enough to say not one session, but 2 sessions for YOSI. I think that speaks volumes. So with that, we'll come to a close with another picture as well. So Manjula ma'am, we can go off live, and we would like to acknowledge Team Numerotech as well for all the seamless support, back-end work, and the whole team behind the flyer designing and all this logistic.
Definitely, sir. Hats off to the team at Mahatma Hospital, because they've been very helpful and pivotal in getting all this, including the backdrop, which was very much appreciated by everybody. So thank you to the designing team there as well.
Thank you, thank you. Manjula ma'am, we can go off live. Go off live.
One second, doctor.